And so, without further ado, I'm going to bring back my good friend and colleague, Dr. Andy Morgenstern, to give us an understanding of why we shouldn't be waiting to have the discussion on dysfunctional lens. It's all yours, Andy.
Awesome. Thank you. Hello, can you guys hear me? Good? All right. Could somebody let the attendees outside know that we're giving away free money inside? We'll have them back in here in 2 seconds. All right. I just want to talk to you guys really quickly. I've had the pleasure over the course of my many-year career of working with Dr. Solomon, Dr. Goel, Dr. Holzman, and Dr. Bruce Rivers. I don't know if you introduced Dr. Rivers before. And Dr. Bruce Rivers. And many other cataract refractive surgeons. And this is probably one of the most important components to getting happy patients and happy surgeons at the same time. And that is, why are we waiting to have the conversation about dysfunctional lens syndrome? And so, financial disclosures. So I've had a lot of fun with, I think I said it before, but I've started to have too much fun with ChatGPT. So I basically, and this is for anybody that lectures out there, this is a really fun way to kind of get your slides better. Take your content, put that into ChatGPT, and ask ChatGPT to give you a picture of what the content is. And so that's how I get these pictures over here. So the first one is, I just want to tell everybody, because I think this is really important, and I'm going to actually ask John for kind of advice. I think there's a part where the optometrist, probably the most important part of getting a patient happy after a refractive lens exchange is having the discussion early in the optometric practice where you introduce the information to the patient that they could have a really great outcome. Nobody wants to hear that they have cataracts, but everybody's going to get cataracts. And even if it's not a cataract that's the problem, in 2025 and moving forward as we do with time, I think we have to realize that both as optometrists and ophthalmologists that we have a refractive tool belt that's pretty extensive, that there are so many ways that we have to make a patient's vision better. And so I say this tongue-in-cheek, but don't be lazy. You need to have these discussions with your patient, because if you don't, your competitor will. Now, if I was, back in the day when I was working with you, if there was a patient that trickled into my office, or I'm going to pick on Sonny just because he's walking in now, doesn't know what I'm talking about. But back when I worked with Sonny many years ago, if a patient came off the street and saw a different optometrist or went to a different practice and came into our office, trust me, we're going to be giving them the options of what they have for refractive surgery. So if you don't have that discussion with your patients, when they're looking for it, and I think it was Dora was talking about how many patients are online doing research, getting this information. If you don't offer that option to your patient, we will. Trust me, we will, because we have these tools in our tool belt, and really, the optometrist has these tools in their tool belt as well. The other thing that I want you to think of is when you partner up with an ophthalmologist, if you're an optometrist and you're partnering with an ophthalmologist to be your cataract surgeon or your or your smile or your laser refractive surgeon, whatever it is, you really need to think that you are each an extension of each other's practice. I think that's really important. So the optometrist needs to partner up with the ophthalmologist, and you're working, yes, there's a word co-management out there, but what you're really doing is you're utilizing your practice to help their practice for the patient's best outcome, and vice versa, where the ophthalmologist is using our practice to help the patient's best outcome. So have the conversations, and have the conversations early is the take-home message. Just remember, we don't offer one flavor of refractive surgery, okay? There isn't just cataract surgery. There isn't just LASIK. There isn't just PRK. You have to have these understand what these options are. For those of you who are working with Dr. Holzman and saw what he has available in his practice or what Dr. Solomon has in his practice, you need to learn about that information because those questions will come up. And if they don't come up, quite frankly, it's our responsibility to educate the patients on these options. So when should you have the conversation Again, I'm sorry, I had too much fun with ChatGPT with these images over here, but it is what it is. I guess you guys are going to have to live with it right now. When should you have the conversation with these patients? Well, in my personal opinion, if you wait for a cataract to happen, yes, you can have that conversation, patient XYZ, you do have a cataract, here's what we have available for you. Is it right to tell the patient, you have a cataract, you can have your lens exchange, we can put a single vision IOL in there, but you're going to have to use reading glasses for the rest of your life. I don't think that's right. I really think it's correct when patients start to question about what options do I have to go through the litany of things that we have available to them. And we're going to talk about that in a second. So patients who are presbyopic, and not because there's a new drug on the market right now, but if a patient is presbyopic and they want options, there are now 3 drugs available on the market for a medicine-based presbyopic treatment. There are multifocal contact lenses. There are monovision contact lenses. There are multifocal IOLs. There are combination treatments that you have to be aware of. All of our patients need these options discussed with them. So when do you wait to have the cataract discussion? Well, for those of us who are optometrists, that I hope none of us have ever done a cataract surgery before, but if you haven't, I would talk to your doctor that's doing cataract surgeries on your patients, and if you haven't visited them in the operating room to see what they're doing and how they're doing it and how they're having their conversation with their patient, to me, that's really important. If you're going to be referring a patient in for surgeries, I think it's important for the optometrist to go visit that doctor at least once every couple of years, get in the operating room, see how the surgeries are going, but more importantly, understand how the surgeons are talking to their patients and how they're explaining their technique, because that language should be used in your exam room. Because if you're referring that patient for a cataract, for a refractive lens exchange, for LASIK, for PRK, the patient is at ease when they get the same information coming from both places. So in my personal opinion, when you have patients with early cataracts, absolutely even if it's a non-surgical cataract, that is the absolute right time to start talking about cataract surgery and getting that patient educated. The other thing is that you don't know how the patient feels. I can't tell you what vanilla tastes like, vanilla ice cream tastes like. I can't tell you what chocolate ice cream tastes like. Your patient is going to tell you that they see okay, they see blurry. When you see a cataract, you can't tell a patient how much glare they have or how much inability they have to see at night or how their driving is. Some patients really want to have those cataracts out earlier than some other patients. I understand, and trust me, I understand the medical indication for removing a cataract, but we have so many great tools, and cataract surgery is I think cataract surgery is still the #1 surgery in the United States. Elective surgery in the United States today. The #1 elective surgery, that's saying a lot because there's a lot of elective surgeries out there. The #1 elective surgery in the United States, we have the ability at a very high rate of success with a very low level of complication to get a clear windshield in front of these patients. I think it's incredibly important to offer up all of these technologies that we have. And these things are just getting better. And quite frankly, I'm in the refractive world. I am looking at this stuff every day. I have Google alerts all over my email. I can't even keep up with some of the lens options that are available sometimes. They happen so quickly. So earlier is better when having that discussion. Earlier is better when you have a patient that may consider a refractive lens exchange. So what option? Oh, here's my tool belt. That's supposed to be an ophthalmologist with all the tools in their tool belt about what they have. Just think that I couldn't get it to put IOLs in there and all that other kind of stuff. But there are so many refractive options, especially in within the operating room and within that ophthalmologist tool belt. Remember, for every single cataract surgery patient, you need to let them know, and I know this is so basic, there are monofocal lens options, toric lens options, and multifocal lens options. The multifocal lens options are getting better every single year. The surgery is getting more and more, I don't want to say simplified, but the technology is getting so much better. It's reducing risk and it's reducing refractive outcomes that are having problems. And we can get these patients much, much happier than we could years and years ago. Always remember that, I know it's silly to say, but a lot of people don't remember to think about ICLs as an option, about implantable Collamer lenses to put inside the eye. I know there's a couple of people in the room, colleagues of ours that are sitting in here that have had ICLs put in their eye. You can combine ICLs with other procedures, which leads me to this slide over here. Don't forget that we can do multiple things on patients to help them out. That we can do a surgery. If a patient has a cataract as in a keratocone, I know it may sound silly, but we can remove the lens, put in a clear window, and still put a scleral lens on top of that patient. So utilizing the ophthalmologist and the optometrist together is critically important for these patients. And with that, I just want to tell you that your job, well, our jobs is to doctor patients, right? We're here to help patients out. They're coming in with refractive problems. You need to remember that we have tons of refractive solutions. And I do want to let you know that in your practice, I know Dora was talking about practice building before, you want to be able to offer all of these technologies, even if you're not doing it yourself, even if you have to refer it to one of the ophthalmologists, whether they're in the room or not in the room. If you don't, one of your competitors will. So I think it's incumbent upon you to learn about all these things, better your relationship with your surgical ophthalmologist, go into the operating room, see what they do, see how their staff talks to their patients, mimic that with your staff that's talking to your patients, because patient education with these refractive options are critically important. I know that when I go to the doctor, if I get one message from the front desk and a different message from the back of the office from the doctor, that tells me that maybe something may not be good over here. Or if I go from one practice to another practice and they're not telling me the same thing, that creates confusion. I think it's incumbent upon us as optometrists to really hone in on that conversation, because it's just going to make for happier patients. And again, I can't say this enough times, if you don't offer it, somebody else will. So please educate yourself, educate your patients, and increase your relationship with your ophthalmologist. If you have a patient that needs a refractive option, talk to them sooner rather than later, because you want to start that discussion, and you don't know when your patient is going to want to kind of cross the line in the sand to go to that surgical option to get their vision better. I know that I've been doing this for many, many years, and I'm still blown away at some of the patients say, yep, I'm ready to do it at 46 years old. I'm ready to have a clear lens exchange. Or, yep, I'm ready to have multifocal lens options, even though I haven't really thought about it before. So I don't know if you have anything to add from a surgical perspective.
So the only other thing I would say, first of all, thank you, Andy, for doing this. And I know we had some time constraints around this. So I also want to give a plug for Dr. Morgenstern's meeting that he does every year. About 3 or 4 weeks ago, IKA. If you have any interest or you manage keratoconus or ectasia, it's a phenomenal forum to discuss what is currently the standard of care, what I think should be the standard of care, and what we're looking to do in the next 5-10 years. I mean, it is an outstanding format. And so for those of you out there that aren't familiar with it, become familiar with it, and Andy's kind of rushing out of here, do stop him. Only other comment that I would make is, and I owe a lot of this to my co-surgeons here, is that when I started doing quote-unquote refractive cataract surgery, it was not uncommon because I didn't have any gray hair. And they'd be like, what's this guy talking about? Because I heard all my friends, they had cataract surgery and they're not wearing glasses anymore. And so the idea of a toric lens or a multifocal lens, and they go somewhere else and they're like, I didn't have to pay for anything. And look, and then they come back 6 months later and they're like, well, I didn't know I was going to give up my near vision because I was a -3. And you're like, what else do you say? I was like, well, I told you. What else do you want me to say? And so my point in bringing this up is that initially your slide presentation was talk to your patients, partner with your colleagues to start the conversation. The idea of presbyopia, these drops, I think, are going to be a wonderful addition to just have a dialogue about it. I rely so heavily on Nancy in our practice and Jen in our practice in Virginia. If you don't have that discussion, you're going to get stuck somewhere. And so hence the whole philosophy is vision for a lifetime. You may be transitioning, you may be myopic, you might be hyperopic. There is a surgical intervention for you. And if we're waiting for you to have gone to 20, 40, or now you're losing your driver's license, we've missed a window that at least allows us to continue to engage our population. I mean, that's the way we approach it in our practice. A young associate, Dr. Siddiqui, and he's already bought into the mindset, a keratorefractive surgeon that's doing grafts, and he applies that same philosophy to somebody who's having a PKP or an endothelial transplant. I mean, we shouldn't just stop by doing the surgery. Look at ways in which to kind of approach this from a refractive standpoint.
Absolutely. Yeah, absolutely. I know she isn't here. She is an incredible friend of mine. I just want to add this to it. I know there's some people that are in the room that are providers of this lens, but my good friend and colleague, and I'm not trying to promote her business at all, but her lens, I can't tell you how great it is. The iPrint Pro, if you've ever heard about it or not, the custom molded contact lens. I know that at our location, we just fit a patient with an iPrint Pro on a patient that the eye survived an acanthamoeba, ended up having to have the graft replaced 2 times after the primary graft, and then ended up with a neurotrophic keratitis that was non-resolving, non-healing. So you have advanced level corneal refractive surgery, multiple grafts that we ended up putting an iPrint Pro on to help the neurotrophic component heal and reepithelialize. And I just got a word within the last 48 hours that the patient's actually way more comfortable and doing well. We put the lens on her 3 to 4 weeks ago, I believe, and I think we're seeing her back in clinic in 2 weeks, but she's healing much better. So you have this situation where it's a non-refractive procedure, but you had multiple surgeries on the ophthalmology side that ended up having to come back to, and I don't want to say it that way because I really think it's a partnership, come back to optometry for the scleral lens fit to get the eye healthy. And you have to remember that, again, when you're partnering up with that ophthalmologist, and I speak on behalf of Sonny and Andy and John, it is a partnership, right? You're taking care of that patient. You're bringing them in. They want them as educated as possible, just like Dora was talking about before, about getting that dry eye and ocular surface healed up as well as possible so they can get them into the operating room, so they can provide the surgery to get them the best possible outcome, so that patient can come back to primary care optometry and you can manage that patient, whether or not you're doing it with a soft lens or a scleral lens or whatever it is. There are so many tools to make our patients happy these days. Again, like we were saying before, talk about it early, talk about it a lot, get the patients the information, work with your docs that you're partnering with, and I think that's how you end up having great patients. And Dr. Rivers as well. I forgot to pick on you in the audience a little bit over here, but I had the pleasure of working with Dr. Rivers as well in some different components. And so, that's all I got to say about it. The reason why I chose to go into refractive surgery early on in my career is because it was so much fun and because there was so much great technology and there were so many diagnostic pieces of equipment, and I got to work with cutting edge, great ophthalmologists, and today it is still the same thing. This is the reason why I still love the refractive component of all this, is because there's great people with great technology, great diagnostic devices, and we make patients happy. And if you think about it in medicine, Sonny, I cut my teeth working with Sonny. From the day that we started working together, he's been making happy patients. And so it's really incredible to be able to do that over the course of your career. Obviously, we get to see sick patients every once in a while, but to make your patients that happy, because, as we all know, vision of the 5 senses, vision, of course, is the most important, as we will all argue. And to be able to give that I hate, it sounds corny, the gift of sight through these different tools is incredibly important. So, yep.
Thank you,
That's all
Andy.
I got. Thank you very much.
Again,
I got 99
Morgenstern.
problems, but LASIK ain't one.
Awesome. Thanks. Thank you so much.
Yep.
All right, we're going to bring back our panel. I'd like to be joined by Dr. Holzman and Dr. Goel, and also special guest here. Dr. Rivers is going to join us here, and we are going to be moderated, or certainly addressing this conversation by, once more, Dr. Weigel. I think you're mic'd up there. Yeah, so you got that. Okay. Thank you, Andy. The sentiment for this component is actually really to kind of discuss how the overall approach to refractive surgery is being viewed by the community, by those out there in the marketplace. And are we actually in control of this message? Or I think Andy touched on it, is social media kind of playing a role, and in that case, potentially a negative role, in what we know to actually not be the case at all? And so the floor is yours.
All right, I'm going to try to stand on the stage because I've never been this tall before. It's actually pretty amazing. All right, I do want to give a shout out to Dr. Solomon for naming this lecture. I've got 99 problems, but LASIK ain't one. I really did not know that you had this music ability. Holzman, yes, you know. This is great. All right, so, I do apologize that Dr. Rivers, that your name is not on here. I didn't know that you'd be here, but I have seen you on Instagram, so it's kind of cool. Right? All right, so negative LASIK media is everywhere. It's not just about LASIK, that's the most popular one, but you need to know that your patients know this, right? So here in this room, we're like, oh, happy, everybody's like great, right? But people are out there finding negative information. You need to know what that is, right? So these are just screenshots from TikTok showing negative media about it. Instagram has it too. Reddit, they go real deep in Reddit, right? Talking about this stuff. Facebook has it. Traditional media will have it. Tons of information there. And then more recently, there was a documentary on PBS called Broken Eyes that was like it was a grueling hour and a half of watching this for the benefit of you guys, right? So, about this one person's experience with her LASIK. So basically, she is a documentarian, so she makes documentaries for a living, had LASIK, and then she ended up having some struggles with corneal neuropathy. And kind of her message, or she feels like in our field that we only want patients to have surgery, healthy patients, right? And then we kind of hide this idea that there exists, that there are negative complications or that corneal neuropathy even exists. And then when she has a problem, she's saying that when she developed an issue, everybody kind of just brushed her off, and then they sent her to a dry eye clinic. She's like, well, isn't that convenient that the person that gave me this problem is now benefiting from me financially by sending me to their dry eye clinic, right? So her presentation basically is like there's this whole negative side of this surgery field that nobody's talking about and hiding it from patients, right? Which I think is kind of I don't know, it's kind of ironic because in her documentary, she's talking about how we are so one-sided, presenting only positive, and yet in her documentary, she's presenting only like negative things. So how do we get here? We get here because of commoditization. And in this process, we take a service and we make it into a good or a product. So that kind of, it becomes like everybody can do this, right? So that's what it is, right? We've lost surgical emphasis. We're saying like, oh, it's so simple, LASIK, even a monkey could do it, right? And right, we have this extreme focus on price point. So even like $299 an eye or $1,000 off, nobody's going to pay retail for it. Why do we even have retail in there? It's the cost of the procedure, right? And then we also have this focus on technology, which is great that patients can get this information, but they will come in and they will ask specifically for topography-guided treatment. Well, that's great. You're a hyperope. You don't even qualify. Like, that doesn't even cover that parameter, right? But what happens when, like, everybody has the same laser? I know you guys don't all have the same laser, but what if you're in a smaller town? Everybody has a Vizx or everybody has a Wavelight. Then how do you distinguish yourself from the crowd, right? And then we also have evolving understanding of lasers, how we use them to help our patients. Also, ectasia prevention and diagnosis. We're starting to understand corneal neuropathy more. I think patients have an expectation that technology changes, but I don't know that they have this understanding that like medical understanding changes too, right? So when they have developed corneal neuropathy, like we're kind of learning too, right, about this. So it's not the secret that we've hidden. It is an evolution of the understanding of the process. So what are the consequences of our actions? As Dr. Holzman referred to before, negative publicity, when it's not easy, when it's not fast, when it's not perfect, people go online and they express their negative experiences with it. We've also kind of devalued LASIK as a medical surgery. You know, yes, we use soft wording like, oh, it's a procedure, right? But it's surgery. Like, you got to take this seriously. And sometimes patients fail to recognize, because it is surgery, they fail to recognize that there are like steps that they need to do. So I don't even know how many times people are like, I have to take my contacts out? Yeah, if you want me to help you, you got to help me. Right? And then we even had one time where a patient called. She was upset because we didn't call her before surgery to read her informed consent to her. Like, it's not story time. You have to be a responsible patient as well. So how do you fight back? And this is what I'm going to ask our surgeons to kind of talk about. emphasis on concierge medicine. So when you come into our office, it is overall a very positive vibe. We're all here to help you achieve your visual freedoms or your visual goals. We need to emphasize the surgeon too. It's not just the technology. You can have a laser and not know how to use it, or not know how to use it quickly, right? So there are some places where when they create a flat light, everybody gets the same flat. That's not cool, right? Because we're all different people, right? So we need to be able to customize things here. We need to listen to our patients, not just brush them off. What are you experiencing? How can I help you with that? Validate what they're experiencing, right? And allow time for proper discussion. They should be able to ask all the questions that they want. For patients that like to ask lots of questions, they like to hand them to me because I like answering stuff. So it's a good match there. But I do want to, before we throw it back to the surgeons, even though LASIK gets these negative things, there's so many other surgeries out there that are just like kind of, I don't know, not throwing shade on anyone, but they're kind of nasty. So like when you're doing this kind of stuff, where's the negative publicity about these things? Oh, splitting her tongue. I don't even know how she eats. But throwing it back to our surgeons, how do you take back the profession that has been kind of from a service to a good? How do you make it back to a service?
Who wants
Dr.
to touch
Osman.
that? Yeah.
Yeah.
Is this on?
No?
Yes.
It is?
Yes.
Oh.
Okay. What's interesting about this panel, as I sit here, we're all, private practitioners running our own businesses at this point. Some of us have come from corporate backgrounds and fought our way out of that. In fact, the two of us right next to each other with the same attorney. Yeah. But what I think is really important is that when patients come in, they're treated really well. And they're treated with the concierge-like service that they deserve. They're spending a lot of money. That they don't want to be herded. We've heard this before. I was herded like cattle through this place, or I waited hours and hours, and the doctor never even saw me, and things of that nature. That's what's killed our industry. And sadly, we have corporate providers in this industry, and plenty of them in the market here, and we know what they're like from personal experience. And I think that's sadly, we as private practitioners, what we have to continue to do is just do our very best to make people happy and just make this experience not only the best medical experience they've ever had, but the best experience they've ever had. And we hear that a lot. Like, this was the most unbelievable experience I've ever had. And that is what is going to drive the market back. Okay, everybody in this room can benefit from that. I mean, you want to have superb customer service in your offices, and if you do, you're going to be okay. You're competing against a lot of corporate providers, and I'm not going to slam all corporate providers because there's great doctors in corporate centers. There really are, but the level of care tends to be different, and because the corporate philosophy is above all, do the case. Do the case, get the patient in. Doesn't matter about, pre-op stuff, some post-op stuff. They don't even care seeing them. And stay in touch with your patient. And I think that's what we all do. And if we do that, and other doctors do that, and you all do that, our industry grows. Okay, despite the negativity. How do we fight back? I mean, other than being as good as we can possibly be, we need to be better on social media. If we need to be educating people on TikTok. It's a sad thing that people get their education on TikTok. But I think my demographic for 18 to 40, for LASIK, most of them are getting their education on TikTok. And so we have to come up with better ways to hit TikTok as an industry with positive messages that resonate. I'm
sorry. I think hold on to this, because I think that is a discussion here that has to be played out. I mean, we just heard from Market Scope that they may be going there for the information, but that's not who's touching these patients, and that's not who's informing their decisions. And so I agree with you. But how are you going to compete with the negative news cycle, where you're never going to be able to put as many messages on there that get traction. So if that's truly the case, I think we are in for a long haul. it's more making sure that the experts who are indeed guiding each patient in the office very well may be the one to ensure that it is at least a level, it's a level discussion to at least start the movement. If somebody has showed some interest, giving them a sense of it. And, maybe what I'm hearing you say is be a little bit more mindful as to where the referral goes from there, because that might actually play a role too. I mean, I'm not saying you're not right. We could, but I think you'll be killing yourself trying to put out ads on social media. And there's nothing sensational about boring.
We can dance.
We could, yeah. Maybe,
the dancing
I don't know about that, yeah.
No?
But, I mean, you have any thoughts on that, Bruce? I mean,
Yeah, I was going to say, I think, well, first, my kids made me promise not to do any dances on TikTok. so I can't do that. Yeah. But I do think education is really important and the experience. And so one of the things, thank you guys for allowing me to be a part of this. One of the things that I really, really like, and I know it might sound crazy, but I refer patients to you guys all the time. Like when someone comes to me and I say, hey, if you want to get a second opinion, I want you to go somebody else that does the exact same thing that I do. And I think that patients appreciate that because they know that obviously if I'm sending them to somebody else, it's somebody I trust. And I think that the other part of that is preventing them from going to somebody else that's going to tell them, you know what, you have to get LASIK, even though you should get an ICL. Right. And so I think just being honest with patients, one of the things my staff laughs about that I love to say this, but if I have someone who's like in their mid-50s, they're a hyperope and they want to get LASIK. And I will tell them all the options and I'll tell them, this is what I think is going to be the best option for you. And oftentimes they'll say, so you say I can't get LASIK. And I'll say, no, I didn't say you can't get LASIK. You just can't get LASIK here because that's not going to be the best thing for you. And I think that patients really appreciate that.
Yeah,
So,
I agree with that. You got to turn people away.
Yep.
Some of the biggest referring patients are the ones that we've turned away over the years. That we just said no to. And, if you just operate on everybody, you're going to run into a lot of problems. And if you turn people away, it's you sleep better and you feel better about what you're doing and it grows your business.
And sometimes those patients have a little mental astigmatism, so they're probably not a good candidate.
Yeah, well,
for anything,
sometimes you have to find out some reason. You have malignant blepharitis.
Some of it is like hand-to-hand combat to some degree. You need to talk to the patient in your chair individually so they understand what their best options are for that individual. And then do the whole customer service thing, as Andy mentioned. Like I call my patients still the night of surgery, and they're just they're wowed by that. They're like, I didn't expect your phone call. I thought it might be one of your technicians or a nurse calling me, but it's me calling them, and it's part of my routine. And then they talk about that. And when you look at our reviews, they mention that, like the doctor called me the night of surgery. And those are the kinds of things that we can't, it's hard for you to go out there because you're very good looking, you're tall, you look amazing. You can't go out there and say, I'm John Sullivan, I'm tall and good looking. You need someone else to say that about you. And so you need patients to say that about us.
Well, again, it's guys like you that obviously keep me employed by, saying these type of things. Thank you all very much out there. I think the other point, so we all have our conversation bullet points and highlights. When I walk into a room and I know we're talking about refractive surgery, regardless, one of the first things I will say is, well, why now? Why is it important for you to proceed with the surgical option now? And who else did you see, if they've seen anybody at that point? Because it at least gives me a sense of from where they're coming, if they're trying to, and then finally, and it's not always in this order, but somewhere is, we're not the cheapest game in town. I mean, if you're looking for that, we are not your center. And so in large part, we certainly highlight the fact that I'm not looking for reasons to rule you in. I'm doing all this work to find a reason why you shouldn't be here and why we shouldn't be doing surgery. Everything that you've each said individually, it's just a way of simply saying you may get the best information from somebody or the best referral from somebody because you said no. I may push back a little bit on that, and as we get into, if we get around to it today, the idea of ectatic patients or people who are formed frust, there are surgical solutions, and we are able to do things. I mean, we were involved in the Avidro study. We were involved in cross-linking.
Those patients are candidates, still, for something.
Yes.
They're a candidate for something, and it doesn't mean that it has to be surgical now. Mm-hmm. But start the dialogue. Let them know. And I think having what I consider friends and say, look, because you oftentimes catch people like a deer in a headlight when they're like, hey, I thought I was coming in for LASIK and it's this much, and now you're saying I have to do that and it's this much. Why would you say that? Well, why don't you go talk to a reputable, colleague who is going to look at you in a similar vein to give you at least a clear sense of it. Because at the end, I said the commodity that I value more than anything else is my sleep. And if I'm worried about you tonight, and I'll tell them this, I don't want to break that up anyway. I got a lot of other things to concern myself with, 99 other problems. So
I will say from an
Nice callback.
from an optometry standpoint, I think there was a mention about, I think Andy mentioned it, Andy Morgenstern, about the optometrist visiting the surgeon to watch surgery, or at least spend a few hours watching consultative processes and things of that nature. And I think that makes a huge impact. And it always has over the course of time for us. And it kind of makes the partnership better. The patient feels better. They know that it's not just a, so to speak, kickback of sorts. I hate that term, but that's, what people will come in saying, sometimes. No, it's a partnership. It's co-management. We work together, and the patient understands that when they come into our office. And we, as practitioners, really like to encourage the patient to go back to the optometrists and to continue their care with the optometrists. Okay, I don't think any of us up here would want to steal any of your patients for any reason whatsoever. I mean, we like working with optometrists. I know there's MDs that don't. I don't think any of us are in that crowd. So I just want to say that if you are so inclined, come to the offices, see what we're doing. Okay, spend a couple hours, and then you'll feel better about referring your patients, and you'll feel, you'll be a better referrer. You'll just be more educated about it.
Great. Well, thank you all. Again, these are my friends. I just want to hold on. There's a question here at this end. I just want to make sure we stay on time because I've already been kind of looped before. Yeah. Is it so? We'll get one question in the back, and then we're gonna have to move on.
You want to answer that, Bruce?
Yeah, I would say, and it's not always easy, but the more educational content you can do, things on YouTube. There was a video someone sent me, the guy's anesthesiologist, and he's talking about LASIK, and he calls the cornea the sclera. And it's a horrible video, but like he's an MD, and so everybody thinks that he knows what he's talking about. And so I think that the more content that you can put out there, educational content, people are going to find it. And a lot of times just kind of making things, I'm a simple guy, making things very simple and understandable. You're not going to be able to combat everything, but I think just trying to win one patient at a time is the best way to do it, I think.
New technology matters. And I think, like we were talking about Wavelight Plus, and I'm sure the advances in SMILE and the advances in IOLs and ICLs, this stuff matters, okay? And so that might start resonating with patients when they start hearing that, the chance of them having 20/20 vision is almost 100%. And that we just have to keep them in the right hands, these patients. We just have to make sure they go to reputable places that are going to take good care of them and not operate on poor candidates. I mean, that's really the key.
Yeah, and I'll go back to my original point, which is why give social media the last word anyway? These patients are sitting in front of you. Take a moment to just kind of debunk it. You don't have to sit in here and drive somebody in, but just say, look, I think we're going to talk about this later, is that there are options. There are glasses, contacts, and there are surgical solutions. You don't need to dive into it, but just express it in a positive vein because that is the reality of it. And so there's no reason to somehow give social media the first and last word. And so,
hold on, I got one quick question to poll the audience. How many of you, and be honest, have said to patients, you really shouldn't have LASIK now because you're going to need reading glasses? Is anybody going to raise their hands? Come on.
Lovely.
All right.
That's right. Candid.
So that, that we hear that a lot, and I think, people, I don't think people like that comment. From what I hear when patients come to see me, when we're talking, when patients will tell me, well, they told me I shouldn't have it because I need readers, but I can't see my kid playing soccer, and I can't see the movies, and I can't stand waking up and not seeing. So readers are one thing, okay, but the world is another. And, you have to make sure you ask your patient when you're going to make a comment like that, well, is your whole world right here? Because if your whole world is right here, then that's a different story, and you really shouldn't have refractive surgery where you're going to need, or a LASIK procedure. Maybe they're RLE, maybe at that point, but try to keep some of the negative thoughts about this in your minds, because there are options for presbyopes these days that work really well. So I'll say that. Yep.
I keep in mind when I'm talking to a patient is like my personal opinion of whether or not you should do surgery. That doesn't matter. We're there to tell you if you can you do surgery, and then the patient can decide for themselves that they should do it, right? So your personal opinion about presbyopia and the use of near vision glasses, really irrelevant, right, to the discussion, because it's that patient's life, and that patient gets to make the decision for themselves. You're just there to provide that information. So it's very different between can and should.
Hear, hear. Well, you don't have to go home, but you can't stay here. Get off my stage. I got to keep this moving.
Okay.
Sonny, you stay here. Actually, don't go home at all because we really want the audience. So I was really kidding. Bruce, don't leave. No, Andy, don't leave. All right.
You want me?
You got to go.
Leaving.
You got to go.
I'm not leaving.
And so I'm going to go ahead and hand the floor. Thank you again to everybody. Dr. Rivers, Dr. Holzman, please, a round of applause. The floor is yours, Dr. Goel. Tell us, piggyback off Dr. Morgenstern, a phakic, no more refractive lens. Give it to me.
Yeah, and this is a nice segue from Andy's comments about reading glasses after laser vision correction. So I'd like to do just a couple of case presentations. You have a 55-year-old female patient. She's a hyperope +3. Her eye exam's within normal limits, normal topography. She's interested in laser vision correction. What do you tell her? Show of hands, anybody want to just screen out what you tell a patient like this? You don't qualify because you're too old. Your prescription's not great for LASIK. You're a hyperope. They don't do as well. You're going to need reading glasses if we fix the distance vision. Is that really what you want, right? But what we should be asking is, why is it you're thinking about LASIK? You need to ask them the questions that drove them to ask the question to begin with. What about your vision is bothering you, right? What is your goal with vision? If you can listen to your patient, you'll be able to find a solution for them. And presbyopic hyperopes have been cursed with blurry vision at all focal points. They are blurry everywhere, all the time. They are the most miserable patients that we have in the office. I think you guys will all agree. So refractive lens exchange is a surgical procedure. It's basically cataract surgery in a young patient, where the eye's natural lens is replaced with an artificial intraocular lens. Some of us call it dysfunctional lens syndrome, clear lens extraction. And it's primarily used to correct presbyopia, myopia, hyperopia, when laser vision correction is maybe not the best solution for them. And again, it's similar to cataract surgery, but done electively, paid for out of pocket by patients before cataracts develop. And if you do this procedure for them, there's no future cataract to worry about because you're going to be taking care of that tissue. The other thing to remember is that if they're paying for this out of pocket, how does that compare to a patient having cataract surgery paid by insurance, but they got to pay for the upgrade to have a multifocal lens, right? So in our practice, we charge about $6,000 per eye for refractive lens exchange. Includes everything from anesthesia to the lens implant to the facility fee. We use a LENSAR ally laser to do our flax, as I'm sure Jonathan does as well. And if we do this on top of cataract surgery, it's $4,400. So the patient's saving about $1,600. But if they're 55 years old, they have no signs of cataracts, they got to wait till they're 70. Are they okay to pay the extra $1,500 for a 15-year better vision? Probably. You have to have that kind of discussion with patients. Who's a good candidate? Well, in our practice, they're typically 45 years and plus. They're presbyopic. They're already using glasses for distance and near. Hyperopes, moderate to severe hyperopia or myopia. -1s or planar presbyopes are more difficult. I tend to turn those away. Now we have pharmaceutical options for them, right? We have some of the reps in the room. Not great candidates for laser vision correction. Either the corneas are too thin, they have dry eye. We're not going to be touching any of that. Refractive lens exchange does not worsen dry eye symptoms, does not thin the cornea. So we're going to be avoiding all of those issues. And they're basically patients who want to reduce or eliminate their use of contact lenses or glasses at distance and near. And so when we have patients come in and they want to have LASIK surgery, and we say, you can have LASIK, but you need to wear reading glasses. You can have refractive lens exchange, which is more expensive, but you get rid of the glasses for distance and near, 85 to 90% of the time, because nothing's 100%. It all comes down to how you want to be seeing after the surgery. So you tell me which way you're leaning. And if it's a cost issue for them, they're going to tell you, I'm leaning more towards LASIK because all I care about is my distance vision. I don't care about reading glasses. And if they have the finances and they really want to see better at distance than near, they'll tell you that too. Well, I really want to have a solution for everything. So you need to ask the patient and sit there with your legs crossed and you're open to their answer without you rushing through the process. The RLE procedure explained, it's basically cataract surgery, right? So an outpatient procedure, about 15 minutes, topical anesthetic drop. We're now using oral MKO melt, which is midazolam, ketamine, and donostron. We're not doing IV sedation for these patients. A small 2.4 millimeter corneal incision. You remove the natural lens using femtosecond laser-assisted cataract surgery. We used to use the Alcon lens. Actually, now use the Ally by LensArt, which is being bought by Alcon, actually. So it'll be one company. And then we put the lens implant in. And then the lens implant is dictated by their goals with the procedure. So we might use a multifocal lens. We might use a light adjustable lens, a toric lens for distance or near, a monofocal lens for distance or near. Again, listen to your patient, find out what their goals are, and then pick a lens that's going to solve that problem. And I don't say to them, tell me if you want a multifocal lens or if you want a toric lens. They don't know what that means. What you do is you ask them, how do you want to be seeing after surgery? And once you tell me that, I can tell you what lens is going to solve that. And then you take the discussion from there. There's no stitches typically unless they have a poor self-sealing wound, but it is a self-sealing incision. They're in the recovery room for about 10 minutes, and then they're driving in 2 days. We do the surgery typically, for me, on Wednesdays. They're driving by Friday, Saturday, after refractive lens exchange. What are the risks and the benefits? Well, the benefits are permanent vision correction. Their vision is not going to change. This does not affect glaucoma. This does not affect macular degeneration, but their refractive error is not going to change going forward. It can reduce or eliminate the need for glasses. Is not 100%, right? I tell them 85 to 90% of the time, taking into account 3 caveats. Number 1, adequate lighting. Number 2, adequate focal point. The lenses are designed for 16 to 24 inches, and we'll go through the lenses in my next talk. And then number 3 is the font size. So if it's too dark, too close, or too small, you'll need reading glasses for that. What are the risks? Infection, inflammation, like any procedure, intraoperative complications. You can have some glare and halo risks with multifocal lenses, which we'll get into. Retinal detachment, rare, but can happen, especially in the high myopes. And then you worry about over-under correction, which I can fix with a laser, or you can do an LDD for a light adjustable lens. And risks are lower with experienced surgeons. I'm actually more nervous with RLEs than I am with cataract patients because we have 0 room for error. Would you agree with that? Oh, yeah. So much more stressful, which is why we have more gray hair, right? Recovery results, again, they're usually better within the first couple of days. Final results in about 2 to 4 weeks. So you should tell them about a month to fully heal. They're on steroid drops for about a month. Avoid strenuous activity for the first 7 days. All your restrictions are 7 days. Eye drops as prescribed for a month. But long-term, they'll have stable vision, reduced glasses dependence. And most patients report a very high satisfaction and improved quality of life. In conclusion, RLE is a very safe and effective alternative to LASIK. Again, I'm not bad-mouthing LASIK. It's another tool in our toolbox for these patients, especially for, let's say, older adults, but it's really middle-aged, like 45 to 50-year-olds who are playing a lot of pickleball. They're very active, right? They're not, they don't just sit around on their with their glasses and have a problem with that stuff. It treats a broader range of refractive errors because there's no limit to what we can treat, high hyperopes, high myopes, and everything in between. Offers the added benefit of cataract prevention, and it is a permanent solution. Thank you very much.
Thank you, Sonny. Come sit down next to me here. We're going to roll right along. Hold your questions for the end of the session. I'm going to bring our next speaker and introduce Dr. Siddiqui. He's already talked to us a little about his experience with Lacrophil. For those of you that, again, aren't familiar with Dr. Siddiqui's practice, he works at Solomon Eye Physicians. He is a fellowship-trained cornea surgeon, and he's going to tell us how individuals who, again, are having cataract surgery can approach this from a refractive standpoint. So give him your attention. Thank you, Dr. Siddiqui.
Well, thank you, Dr. Solomon. Thank you, Dr. Goel, for your excellent talk, because it kind of is a good segue into my talk. So we all know refractive cataract surgery has the ability to help our patients become less spectacly dependent. But the question is, and I don't have financial disclosures, at least not yet, but can we use most cataract surgeries, if not all cataract surgeries, as a refractive surgery, as an opportunity to help reduce spectacle dependence? Well, premium IOLs allow us to do just that. But the challenge comes is when we're faced with complex eyes. So these are eyes with glaucoma. So, mild, severe, advanced glaucoma or macular degeneration, keratoconus, diabetes. You could add ERM, macular pucker, post-refractive surgery, your post-LASIK eyes, post-PRK, post-RK eyes. And the goal, ultimately is we want to maximize their uncorrected vision, minimize their risk, and help manage their expectations. So we all know premium IOLs come in different variety nowadays. Every week there's a new IOL. So monofocal IOLs give us sharp vision at one distance. Typically it's at far, but it could also be near. Nowadays we have lenses that are monofocal plus, so they give a little bit of extended depth of focus for some of our patients. And with the benefits of those lenses is you get slightly less dysphotopsias. Then we have your multifocal lenses, your trifocal lenses give you a good range of vision. Sometimes they can have glare and halos. You have toric lenses that correct astigmatism, not mental astigmatism, but refractive. And then we have LALs, which I like to tell my patients it's like a bespoke lens. It's like getting a custom tailored suit, basically. In a moment, in my next talk, I'll be talking about the Apthera IC8 pinhole optics. So we have a lot of different options here. And then we have a patient who has various comorbidities when it comes to their eyes. So patients can have a very advanced glaucoma, macular degeneration. Their corneas could be warped from keratoconus, diabetes-related macular edema, retinopathy, post-refractive eyes. So one size doesn't fit all, and you have to do a tailored approach. But the question is, should we turn down a patient and their desire to upgrade their surgery to a premium cataract surgery just because they have these ocular comorbidities? Well, it's, like I said, a tailored approach. So as you know, glaucoma can cause reduced contrast sensitivity. So you typically want to avoid multifocal lenses. However, it's important to stage glaucoma because ocular hypertension, someone simply having higher eye pressures than normal, is a totally different patient than somebody with 0.99 cup to disc ratios. So you have to make that judgment call when you see the patient. And for most patients who have ocular hypertension, mild or even slightly moderate glaucoma, you could consider an extended depth of focus lens. Monofocal is always the safest choice, but if testing shows that their glaucoma is somewhat mild or they haven't endured any glaucoma damage yet, you could consider more premium options. Certainly if they have astigmatism, offer them toric lenses, offer them light adjustable lenses, give them that premium experience, that bespoke experience. So certainly you want to assess the stage and progression of disease as you're counseling these patients. With similar story with macular degeneration and ERMs and other macular pathology. As you know, macula limits your vision regardless of lens choice. ERMs can cause metamorphopsia. So typically, I would say multifocals should be contraindicated for such patients. However, again, you have to take a tailored approach, study their macula, study their testing, and make that decision. Monofocal and typically EDOF lenses are safest for such patients. But again, if astigmatism is present, we should offer them toric lenses. We should offer them light adjustable lenses. We should counsel them that though the lenses cannot overcome their retinal disease, from a refractive standpoint, will help zero them out. So we have to focus on maximizing clarity and not necessarily spectacle independence. So what about eyes with keratoconus or irregular corneas? So I would say typically multifocal lenses, not the best choice for eyes that are what I like to call deranged corneas. But if based on the topographic pattern, you could consider a toric IOL in a keratoconic eye. You could consider an aphthera optic, a pinhole optic in an eye that has an irregular cornea because it can help to decrease some of the higher order aberrations and overcome them. And then perhaps even after a successful cataract surgery, patients would have better tolerance for scleral lenses if you can correct some of their spherical refractive error. So careful testing is absolutely necessary. In diabetes, you want to study their macula, study their stage their level of diabetes, and typically the safest choice is a monofocal, but you could offer them an EDOF lens. Now, if it's very mild diabetic retinopathy, or if in fact no retinopathy is present, again, you have to tailor your approach. Could they be a multifocal candidate? If they have good blood sugar control, why not? If their macula looks healthy, and if they have good control of their glucose. So what about patients who've undergone RK or have history of LASIK or PRK? Because that makes your IOL calculations very difficult because the way the modern devices measure the cornea, it's not often accurate because of changes we've made to their corneas in the past. So typically multifocal lenses can underperform in such patients, but again, you have to study their topography. Certain LASIK patients, post-LASIK patients have reasonable topography that they would ultimately have good outcomes with a multifocal lens. Or you could offer them an extended depth of focus lens, which are more forgiving, and certainly the Pinhole IC8 lens, which I'll talk in a moment. But light adjustable lenses are typically the preferred choice in our practice, and I'd be curious to hear your thoughts on it as well. So that can help give us the control and give our patients a more bespoke experience. So counseling and shared decision-making is the key here. You want to tailor your approach to a patient. You really want to make sure you do all the studies, the measurements, the diagnostics, and assess their lifestyle, their motivation, and set appropriate expectations. Use all the tools that you have available and emphasize the trade-offs, clarity versus spectacle independence. And then, so ultimately, you have to, turn certain patients away, and your patient selection will ultimately lead to better success rate. So summary, take home. So refractive surgery, cataract surgery should be a personalized experience in medicine. Though complex eyes can narrow your lens choices, it shouldn't keep you from offering a premium surgical experience for those patients. Avoid multifocal lenses in eyes with reduced contrast sensitivity and macular disease, and provide clear counseling so that we can achieve best outcomes and patient satisfaction. Thank you so much.
Thank you, Dr. Siddiqui. Let's have you take a seat, and we're going to bring up our next speaker, Dr. Nancy Draskovic, who's going to share her experience with the light adjustable lens. Fortunately, we had early exposure to this lens as part of the clinical trial, as well as kind of understanding with the communication with this company back in 2012. And so when this came about, it was something that we definitely wanted to look at. And you've done more adjustments than anybody I know. And so you're the right person to talk about it. So without further ado, go right ahead. Give us that consensus on light adjustable.
Light adjustable lenses. When no one else will correct you, the light adjustable lens will. Not exactly. But where did this lens come from? So it was developed to address the limitations of traditional intraocular lenses. It is the first FDA-approved adjustable lens technology, and it allows for customization of refractive error after cataract surgery, which is pretty exciting. And it's really useful in those patients that have unpredictable refractive outcomes. And we'll talk about those a little bit more later here. So mechanism of action. Can we get the presenter view of this? That'd be great. Thanks. So this is a lens the lens material is a photosensitive macromer. It's activated by 365 nanometer wavelengths of light. It is a non-invasive UV light that's going to reshape the lens to achieve the refractive power that you're looking for. Multiple adjustments are possible, and then lock-in treatments at the end are going to stabilize your final refraction. The light adjustable lens can correct up to 2 diopters of spherical refraction and about 3.5 diopters of astigmatism. In this photograph here, this is me using the light delivery device system in order to apply the light treatment to a patient. You place a contact lens, it's a gonio light contact lens, on the patient's eye. The purpose is to stabilize the cornea as well as to be able to focus the lens. The treatments will last anywhere from 14 seconds to 144 seconds. What determines the treatment length? I have no idea. You would think maybe a little treatment is a little duration and a lot is a lot. It doesn't work that way. It's really a mystery. Once the device does its calculation, it pops up and it tells me how long the treatment is. And I tell the patient at that point, but there's no predicting of that. I don't know if anyone else has been able to figure that out, but it makes no sense to me. Side effects, there are some patients that will experience a little bit of erythropsia, which is reddening of their vision after the light treatments. This is really something that's transient. It'll last up to 3 days, and it does resolve on its own. It's really important to tell the patients about this so you don't get that phone call in the middle of the night saying, I just woke up to go to the bathroom and everything looks red or pink. And so save yourself that phone call. Just let the patient know up front. How does it work? So the doctor is going to use this beam of light in order to focus it onto the lens. That light then will cause a photopolymerization of the macromers that are located on that IOL. That process then causes a shifting and movement of those macromers. They're going to move into some position that's going to correct your refractive error to achieve the sphericity or asphericity that you're looking for. Once you get that desired result, you're going to use a wider beam of light, which is your lock-in procedure. The very first lock-in procedure is going to stop all those the macromers that are on the lens from moving any further. So any macromer that didn't have an initial treatment is going to be kind of locked in place. And just in case there's some macromer that just kind of hung out there and didn't get activated or deactivated by the light, the second lock-in treatment is going to ensure that everything is fixed and nothing is moving any further. We have 2 versions of the light adjustable lens, the standard light adjustable lens as well as the LAL+. These are both proprietary silicone materials that contain the photosensitive macromers on them. The LAL+ is an actual aspheric design, so it does have a little bit of central power, so this does allow a little bit more of depth of focus. So patients with this type of lens will have a little bit better intermediate range, and in some patients even a little bit more of a near point range there. So we have 3 opportunities to adjust this lens. If a patient comes in after cataract surgery and they're at their target, they've got a plano refractive error, we still have to induce that first primary treatment. The primary treatment, some magic happens out of that LDD device and it does whatever it's supposed to do. Once again, I have no idea how that works. There are engineers that have designed this that are way smarter than I could ever pretend to be, but it definitely does work. But you have 3 chances to have refractive adjustments. So a patient comes back, your quarter diopter off, go in there, do another treatment until the patient gets to their desired refractive outcome. After that's done, we've got 2 lock-in treatments that are required for every single patient. Those lock-in treatments are once again going to fixate those macromers in the position that they're at to stop any further changes. And that leaves us with 1 happy patient that's achieved their refractive outcomes. So it's very exciting. Patient selection. So at Solomon Eye, we actually, I think we're the first on the East Coast to offer light adjustable lens technology. We started doing it in 2019. So we have decided to offer this to patients where other lens options are not the most ideal. So any patient that's had any previous refractive surgery, whether that's LASIK, PRK, RK surgery, patients with complex corneas, any patient that's got Fuchs dystrophy, anything that's going to cause difficulty in achieving and predicting those refractive outcomes. There are cases where we'll have a retina surgeon send a patient over to our office. Their patient is actively undergoing retinal treatments, but they have a cataract that's impeding the visualization of the retina, and they want that out to make their job easier. Well, that makes our job harder because we don't know what that refractive outcome is going to be, and this is actually a great lens for that. We can implant the light adjustable lens, and once the patient's retinal situation is stable, the patient then can come back to us and do their light adjustments. The only downside to all of this is the patients are required to wear UV glasses at all times until their second lock-in. Actually, 24 hours after their second lock-in is done, then they can stop wearing the UV glasses. So that's not always pleasant. We've definitely had patients that come in and say, well, my daughter's getting married this weekend, and they're wearing their UV glasses. And so not ideal. Take them off quickly for a photo, put them right back on. But they do have to continue to wear the UV glasses. We just don't want any external UV exposure to cause any early changes to that lens that we may or may not be able to correct later on. How does this work in real life? Well, our X-Site actually did a clinical trial, a phase 4 clinical trial of, I think it was 143 patients, and they tested to see what their outcomes were with the light adjustable lens. And about 31% of the patients were at target after their light adjustments. About 76% of those patients were within a quarter of a diopter of that target range. 93% of those patients were within half a diopter, and 97% of those patients were within 3/4 of a diopter of their target range. At Solomon Eye, not to brag, but I'm going to brag here a little bit. We had about 50%, we have in the first 500 cases, 50% of our patients met their target after the light treatments. About 67% of our patients were within a quarter of a diopter of the target range, and 100% of our patients were within 67% within a quarter diopter, and 100% of our patients were within a half a diopter of their targeted range. So, and as a little aside here, these weren't our typical virgin corneas. Remember, we're using our patients that have had previous refractive surgeries, patients that have unstable corneas, and within that, 100% of our patients are within that half a diopter of their targeted range. So it's quite impressive. We have to manage patient expectations. That's really the most important thing here. This is still a monofocal lens. This is not a multifocal lens, and patients are spending a lot of money on a lens that they're still going to need to wear reading glasses for the most part. Yes, we can introduce some monovision, but monovision doesn't work for everybody, so really managing expectations. It's great for those complex cases where, the multifocal is not a great option, but the patient wants a little bit more. With 67% of those patients being within a quarter of a diopter range, this is really a great option for those patients. We need compliance by the patient. We need to make sure patients are coming back. This is a long process. This isn't just you had surgery and then great, you're done. We're spending at a minimum 6 weeks with our patients that are having bilateral surgery. That's assuming everything goes as planned and we're being able to perform the procedures and their light treatments, and then they're done. So it's a journey. We get to know each other really well. And it's just, once again, we all keep talking about this toolkit. We've got a lot of tools in our toolkit here. Team-based approach, we rely on all of our ODs that refer patients to us, get those patients started on their dry eye regimen. I can't stress enough the importance of managing the ocular surface. All of our patients, 100% of our patients are started on a dry eye regimen that's more than just artificial tears before surgery, and they're being managed with any sort of drop regimen during their procedures, as well as most of them stay on some sort of dry eye regimen after cataract surgery. Inflammation you have to watch out for that or any sort of corneal swelling, any sort of rebound inflammation. We don't want to rush our treatments. The most important thing is to keep that patient stabilized, manage the underlying medical condition, quiet down that inflammation, and when everything is quiet, then continue to move forward with your light treatments. Optimize that surface. I think we're done. Thank you,
Nancy. Thank you. Yes, lovely. Thank you so much. We're going to hold the questions until the end of the session. I'm going to give the floor back to Dr. Goel to give us an idea of where we stand, the current state of affairs with diffractive extended depth of focus IOLs, euphemistically known as multifocals, presbyopia correcting lenses.
Correct.
So the floor is yours.
Great, thank you. I'm going to wait for the slides to come up. And so this is going to just kind of dovetail into my previous talk about, it's actually not on the screen, I see it on the mirror. But in my previous talk about refractive lens exchange, and then talking to patients about which lenses are best for them, I'm going to just come down and look at the screen because it's not coming up on the screen. So case presentations. And again, I use Andy Morgenstern's lead and got these off ChatGPT. But so we have a 58-year-old commercial airline pilot that's coming in. Refraction, again, he's a hyperope of plus 250. He's interested in better vision, but he's wary about having glare and halos because he flies. And his needs are to look through the cockpit windshield to see what he's seeing, and of course to look at the cockpit controls. And so here's a generated slide again from ChatGPT. You can see the runway on the left. That's how it would look to somebody who's looking at a traditional, traditionally like we would. And on the right, I just had it, bump up some of the halos you might see around the landing lights. And so that's not quite what an airline pilot wants to see when they're landing a plane full of passengers. At least I don't want my pilot to be looking at that. And then case presentation number 2, completely different. So you have a 45-year-old accountant who's a -6 myope, and her world is in front of her. Her goals are better uncorrected distance and near vision, so she can work on the computer without readers, and is not as concerned about having glare and halo symptoms at nighttime when she drives. So when you compare the two different lens options, the EDOF versus the multifocal lenses, the EDOF lens is going to elongate a single focal point to create a continuous range of vision. They have excellent distance and intermediate vision with what we call functional near vision, which means it's not quite the smaller print, more like the 12-point font, if you will. Has better contrast sensitivity with less dysphotopsias, whereas a diffractive multifocal lens will split light into multiple distinct focal points. It'll give you excellent 3 different focal points of vision, giving you greater spectacle independence, especially at near. But you can have worse contrast sensitivity compared to the EDOF lenses with the risk of more dysphotopsias. Here are 2 different EDOF lenses. So we have the J&J Pure C lens on the left, which is coming next year, I'm being told, and then we have the current Alcon Vivity lens. And if you look at the light spread on the right-hand side there, you'll see where the light is. That's what's being focused. So you can see the focus is happening more at the intermediate range and the distance range, and not so much on the near end of the spectrum, which is to the left. And here, by contrast with the multifocal lenses, you have here the Odyssey, the Panoptix, and the Envy. Odyssey, J&J, Panoptix, Alcon, Envy is Bausch & Lomb. And if you look again at the light spread functions here, you'll see that you're getting a greater range of light being spread across the full range. Thank you. Thanks, guys. Got it. From distance to near, you're going to see a greater range of light coming across. And so if you look at these lenses, you guys are good, side by side, you'll notice that the multifocal lenses have more rings compared to the EDOF lenses. And then I'm going to put the light spread side by side. You'll see on the left-hand side of the EDOF lenses, you're not getting that near acuity on the left side with the EDOF lenses like you can with the multifocal lenses across the entire spectrum. So which IOL should you choose? And again, it comes down to listening to your patient, right? If the patient is more interested in having good distance and intermediate vision with less visual disturbances, better contrast sensitivity, and they're okay to wear reading glasses, then I might choose an EDOF lens for them. Right? It's all about lifestyle and their occupation. If, however, they're interested in more independence from glasses, understanding it's not 100%, as we discussed earlier, it's like 85 to 90%. What do you tell your patients, Jonathan? I'm curious.
Independence, I mean, it depends on if you're looking at the DFU, but you're upwards of 90 plus. I mean, across the platform. I mean, it's impressive. But to your point, there are other aspects you described. Contrast, bright lights, and of course size. So
and plus, I don't want to overpromise either. So
That's right.
I'd rather underpromise and have them be very happy with me afterwards. And they'll have the sharpest vision possible at near, and they're willing to accept the risk of having glare and halos with reduced contrast sensitivity at nighttime. And the analogy I use, because we tell them about neuroadaptation, which can occur over about a 6-month period, but the analogy I use is when you go to the airport to fly, you get there 2 hours in advance, you kind of hear the overhead announcements, but you kind of tune them out, right? You're talking to your spouse or your friend, and you're getting ready, you're hanging out in the lounge. You don't really hear anybody else around you. But then when it comes time to fly, leading up to about an hour before your flight time, you start paying attention to the overhead announcements. They've always been there, but you've ignored them. And so I tell the patients the same thing when they're driving at nighttime. They're going to tune those glare and halo symptoms out. If they look for them, they will see them. But otherwise, your brain's going to just see it as background noise, and you just tune it out. Thank you very much.
Thank you, Sonny. Yeah, I think, once again, we're going to hold any questions until our final speaker here, and I'm going to bring Dr. Siddiqui back up here. I'm going to hold Dr. Goel up on stage here. So bear with us here as we come to the end of the session, and I think this is a novel lens that's going to give us, again, another arrow in our quiver to kind of review for these patients who are looking for refractive outcome.
Well, thank you, everyone, and thanks for putting up with the AV issues. Reminder, inaugural event, so thank you so much. So no financial disclosures. So introducing the challenge. So cataract patients often have corneal irregularities in combination with presbyopia. So standard monofocal IOLs limit the depth of focus. So then we think about multifocal and trifocal IOLs. And so as we discussed, there's typically issues with halos, glare, reduced contrast sensitivity with those lenses. So we need a solution for dysfunctional corneas and still be able to provide them with a range of vision without any, or at least minimizing optical side effects. So that's where the concept of a pinhole optic comes in. So on the right, you're seeing pictures of corneal inlays. So these were inlays that we used to do about a decade ago. That's sort of gone out of fashion since then. But the idea is that the small aperture blocks peripheral unfocused lights, and it allows a central focus light to come through. And the effect that you get is you get increased depth of focus, and you get reduced aberrations. So it's almost similar to squinting in a way, which gives us clearer vision. So that's the basis of this IC8 lens technology, and that is the Epthar IOL. So it's a small aperture extended depth of focus lens for distance and intermediate lens. It's a hydrophobic acrylic monofocal IOL with this embedded central opaque annular mask. The aperture size is about 1.36 millimeters. And the idea is that it will help to reduce higher order aberrations as light is entering your eye. It's approved for patients with cataract surgery, and it's typically used in patients with corneal irregularities, irregular astigmatism, and prior refractive surgery, such as RK. The way it works is that the small aperture basically masks and filters unfocused peripheral light rays as they're entering the eye, and it improves the image quality in the process in the presence of irregular corneas. And as a result, it also helps it provide extended range of focus, so better vision, certainly at distance, but as well as intermediate and sometimes near as well. And it's designed to help achieve a certain degree of spectacle independence. And we could, typically in our clinically, what we sometimes do is we place this lens in the non-dominant eye, so it acts it provides a good setup for a mini monovision. So here's a surgical clip of me inserting this lens. So it's about a 3 millimeter incision, and it's placed in the eye just like any other intraocular lens. You want to make sure that it's nice and centered and placed inside the capsular bag, and make sure you center it on the 3 Purkinje light images. And that's it. So the methodology is as if you're putting in any other intraocular lens. Clinical outcomes have been promising. They've showed improved uncorrected distance, intermediate, and near vision. Patients end up with high satisfaction and less dependence on glasses. The reports of halos and glare is minimal compared to multifocals. And you also get a little bit of a toric effect with these lenses because the pinhole effect helps to mitigate impact of up to 1.5 diopters of astigmatism. And it's particularly effective in aberrated corneas, such as those that are post-RK, post-LASIK, irregular corneas, keratoconus eyes. And so key study data that was done in 2018 showed that mean binocular uncorrected distance vision of 2020 was achieved with uncorrected intermediate vision of 2025 and uncorrected near vision of 2032. And the FDA trial showed 89% achieved 2032 or better at all points of distance. And 92% of the patients reported reduced spectacle dependence. And you can implant this lens and still maintain a high level of contrast sensitivity when you're comparing to multifocal IOLs. So indications, we've already touched on. Limitations, it's not an ideal lens in an eye that has corneal scarring. Typically would not recommend bilateral implantation because there is a slight loss of light transmission, and sometimes patients can experience a little dark shadow, especially if this lens is in their dominant eye. So you have to be careful about patient selection. And it's not indicated for patients with advanced macular pathology or severe amblyopia, anything where limiting light going into your eye could affect your overall quality of vision. In the future, potentially expand the application of this with potentially binocular placement in the future. There might be a role for it in refractive lens exchange for presbyopia correction. And perhaps corneal inlays will make a comeback in the future and maybe work in concert with these intraocular lenses. So again, I see it at Athera, small aperture pinhole technology provides good depth of focus with minimal optical side effects, good for patients with irregular corneas, post-refractive eyes, and outcomes show good patient satisfaction, high levels of spectacle independence, and it represents an important step forward in IOL innovation. So it'd be interesting to see what comes next. So thank you so much. Thank you all.
Thank you. So I'll open this up to the audience or to give you an opportunity to kind of ask those questions now that we've kind of finished our morning session. Any questions for any of the speakers? Or is everybody eager to get to lunch? Andy. Yep.
You said that it's not really a multifocal, the LAL, right? But you have the LAL and the LAL plus. Are you guys doing, I think, with, one eye with the LAL and one eye with the LAL plus and enjoying that, or are you starting to slow that back down? Or?
We're slowing that down a little bit. There is a little bit loss of contrast sensitivity with that LAL plus, and I think we tinkered around with it before. There is definitely a lot of talk in offices that do it, having the dominant eye with the standard LAL and the non-dominant eye with that LAL plus. I feel like we can kind of achieve things a little bit better with having that sharper contrast sensitivity and just inducing a little bit more monovision in the patient, and those patients do seem to be very successful with the lens, a little more so than the LAL plus, but there's definitely a role for it.
And you're telling everybody to wear the UV glasses indoors as well, all the time?
Yeah, so that's a trick question. It has not been, there is an active shield that is coated on the lens that does protect the patients from external UV, but it has not been FDA approved as being able to walk around without those glasses, UV glasses at all times. So for that reason, I will say, if patients are really pressing and asking, I will give them that bit of information, but for the most part, I don't tell patients that, and if they're wearing their glasses all the time, great, and if they forget sometimes, it's okay. I'm not panicked about that.
Okay.
Yeah.
Question.
Not a problem. Not a problem.
Yes, I actually have done that.
So the question was, could you, for Dr. Goel, could you leave someone in a kind of a mini monovision setup with the distance eye and then the non-dominant eye at a low myopic outcome is the question. Is that correct?
And that's a great question. And yes, I have done that for patients who, and they have to be willing to give up some of that distance vision in the non-dominant eye. And it comes down to, again, their activity levels, right? A lot of them are playing pickleball these days, and so they want that depth perception at distance and near. But yes, I have done that in the right patients.
Okay, I got a couple questions. Oh, sorry, Dr. Weigel. Yep.
Dr. Siddiqui, are you able to do cataract surgery if a patient has a previous corneal inlay? Do you have to remove the inlay? You keep it in there? How do you do that?
Great question. I mean, typically inlays, hard to encounter them these days. Most of them have been, I guess, taken out. But I would probably first remove the inlay, stabilize the cornea, and then remeasure and then consider what the next options are. And that could be doing an IC8 or other forms of IOLs. Yeah.
Well, so what if you have a patient that's coming in and has some nuclear changes, but, and again, I know this is a big if, but let's just say, but they're happy with the corneal inlay.
If they're happy, then I would leave it in place and consider like a potentially a monofocal lens for them, or light adjustable, actually.
A light adjustable.
Yeah.
Or monofocal with the understanding, obviously, that there's greater challenges getting behind that vinyl inlay to see behind it, both technically and
Surgically,
with regard to eye and surgically.
Yeah.
We would say that for sure, right? So there is some challenges associated with that.
Yeah.
We have an optometrist here that has a camera inlay in her cornea today. She's here now. I don't know, is Donna's still around?
And then we still have.
You're freaking her out, maybe over there.
No. In fact, that was my point. I mean, you can't. If somebody's happy, I'd say leave it. I think it would be reasonable to leave it. Did you do inlays?
I did not do any inlays.
Yeah, good for you. Yeah. Andy and I both did, and they haven't all been removed. I have patients with the raindrop that I still see. I know you've seen them. Yeah. And they're doing quite well. And for those of us who, again, are now knee-deep in presbyopia, there's some really happy patients. And so I really want to be mindful to say, when they work, they work. That being said, I know you put a ton of effort to make sure, the IC8, and it'd be easy to kind of throw shade at you, but the raindrop, similarly, you had to line that up on the visual axis, which from a surgical standpoint was no joke. That was a lot of effort on your part, or at least on the part of doing that. So I will say that. Just practical, rubber meets road here. The other question that I would throw out to you, and if it's not a yes or no, would you consider a multifocal in somebody who has an epiretinal membrane?
Depends on how symptomatic they are from it and the extent of the epiretinal membrane. But I have done it in the past, and I've had good outcomes from it.
I've done it with retinal blessing. So I send it to the retina specialist first, let them evaluate it, and tell me if they think they're going to need to peel it or not. And if they usually come back and say, you're okay, or they'll come back and say, don't do it.
Yeah. And, I can just, that's to me the ad absurdum part of this conversation. A premium lens doesn't mean a multifocal. And in fact, in my mind, I think it is the language, the actual lexicon is wrong. There's no premium lens. There's no premium laser. Nobody buys a laser. And I say this to patients. You're not buying a laser from me. You're not buying a lens. You're trying to get the premium visual outcome. And so if you're correcting 0.2 of a diopter of astigmatism using a monofocal lens, and that patient has a degree of blended monovision, that is a premium surgical outcome from a lens perspective. If you go from 2 diopters and you're putting in a toric and they're not a great candidate for a multifocal and they have a blended vision, or what they wanted was the best distance vision you create, that is a premium lens-based procedure. So I think we have to change the mindset. It's not, the premium isn't in the implant. It is the level of service. Do you offer a lifetime guarantee for your patients? Or?
Yeah, we do.
Yeah,
Yeah.
so do
if
we.
you need LASIK afterwards, we'll take care of it.
Yeah, and so remember, that's not free. We tell our patients we treat every single one of their refractive outcomes for a lifetime. And if that means we're making an exchange or we have to modify the optical outcome, that is now our responsibility. I like to say, as soon as we agree to operate, your eyes then belong to me. And it's our job to make sure we deliver. This is a long-term pad lease. These are your eyes. But we are going to step in and make sure that we are along the ride with you to get to that visual outcome. And so, yeah, it is a premium service. You're not selling a commodity of a lens or a laser. So I hope that sentiment is shared across the room for what it's worth. And so.